All right, so let's talk about the blood gas. So when we talk about blood gas, we have to divide it into 6 things that we really talk about and think about when we do the blood gas. Number one, and you have to do that for every blood gas from now on, if you're not doing it already. So this way, by a year from now, if you do it on every blood gas, then it's going to be second nature. And you really don't have to go through the whole list of 6 things to do, because you just can quickly find out. So, number one, you need to find if it's acidosis or alkalosis. And that's very easy, obviously, right? pH above 7.4 is alkalosis, below 7.4 is acidosis. Number two, you need to find if it's respiratory or metabolic. Right? And that's also easy. If the pH is going in the opposite direction of the PCO2, it's respiratory. So if I have 7.2, 60, that's respiratory. If I have 7.2, 20, that's metabolic. Right? So that's easy. Number three, if it is respiratory, and only if it's respiratory, then we divide into, and please do it this way, please forget, if you read, you know how many times I read the acidosis chapter or the acid base chapter, and about maybe 5 times when I was a resident. I grasped nothing out of it. I forgot everything when I became a fellow, because it's full of junk, fat. You know, things that you don't need in clinical life, and you don't know as you're reading which one is gonna benefit from, or which one you're just doing it for the test, right? So I've seen a lot of people jump from here directly to the chronic or acute. It's like, to me, they guess, okay, well, chronic, acute, if it's 0.3, 0.04, but confusion. Just determine if it's respiratory or metabolic, and try to remember less formulas than you normally remember, because you can't store everything in your peripheral brain. Yeah? And on the run, you have to really think with your brain. The phone is not going to think for you. Okay? So respiratory, you have to decide if it's pure respiratory or mixed. It's another disorder with respiratory. So, and that's very easy. You have to remember one formula. A change of the PCO2 of 10 results in a change of the pH of 0.08 in the opposite direction. In the opposite direction, right? So if I give you 7.2, 80, then what you do is that you say, okay, this is first step acidotic, respiratory, because this is going up and this is going down. And then the next step, because it's respiratory, we're going to do number 3, if it's pure or mixed. So this is a change of 40, right? So 4 times 0.08 is 0.32. So this should have been 7.08. It's going down by 0.32. But it's not 708, it is actually 7.2. So that means something else brought it up to 7.2. Right? That's how it works. So right off from here, I know that it's a mixed disorder, just by looking at the gas like this. And that's why I sometimes laugh at people who say, well, we don't know what his normal, what PCO2 he lives at. Let's call the other hospital. Let's get that. We're waiting for the record to know what his usual PCO2 is. It's a fallacy. That's wrong. I can tell you what not exactly, but I can tell you very much in the ballpark where is this patient's PCO2 is. Why? How? I just want to make this 7.4. Because don't believe anybody that will tell you that, especially if wearing a bow tie, don't believe it, because they're going to do like this. So you look at the bow tie and then they say anything. I'm just joking. But anyway, so don't believe anybody that tells you people live at an abnormal pH. Nobody lives at abnormal pH. People live at a normal pH, they live in abnormal PCO2, and they compensate, right? You're probably looking at me like, why is he even telling us? We know that. No, you don't, because, or some people don't, because I've seen people send patients home with 7.22 pH, thinking that it's Pickwickian syndrome. She lives like this. No, she doesn't. If you send somebody home like this, three things will happen. Either she'll die, or she'll correct herself, or she come back to the hospital. And that patient condition, she came back to the hospital. So that's what happened. So how do we know? So we want to make the 7.2, 7.4. So let's reverse it now. Every 0.08, you have to bring down the PCO2 by 10. So 0.08, another 0.04, so that'll be all 0.2. So we need 10, 10, and 5. So we need 25. We need 25. This is 10 of the PCO2, and this is 5. So this one should be 55 for this pH to be 7.4 in that patient. So that patient runs at 55. It could be 60, it could be, it could be around that number, but he runs at 55, and acutely he went up to 80, and that's why he showed up in the hospital, and that's why his pH is 7.2. Number 4, that's the one that you guys you're waiting for the whole time, acute or chronic. Well, at least that's the one that people come primed, like everybody's like primed to think about this. Acute or chronic, compensated or partially compensated, and all of these things, right? So I'll tell you one thing about that. So you really don't need to, you really don't need to do a lot here. But the main thing that you need to remember, that will make it so easy for you here, is just remember that the respiratory compensation for metabolic disorders happen immediately. Doesn't have to be complete, but it happens immediately. And the metabolic compensation for respiratory disorders takes time. It takes about a day or more. So that makes it easy for us. So if you find somebody that is like this, 7.4, 80. Let's say, make it easy, 7.39, 80. So this is acidotic, respiratory, and we can tell that this is 7.08, right? Right, so this one it goes up. This will be 7.08, and something brought it up to 7.38. So it's mixed. Now we're gonna go to number 4. Is it number 1? Is it partially compensated or fully compensated? So we said this is acute. This is respiratory acidosis, right? But is it partially compensated or fully compensated? Why partial? It's fully compensated. Because, and that's very easy. You don't need to do formulas or anything. Just look at this number. Is it normal? Yeah, if it's normal, then it's fully compensated. If it's abnormal, then it's partially compensated. That's simple, right? The next step is acute or chronic. We have to think. It's respiratory acidosis. The compensation for respiratory acidosis is by doing what? By raising the bicarb. That's by metabolic compensation. That takes time, so it must be chronic. 73880 must be chronic. Right? So when you see something like this, don't freak out. The PCO2 is not what's putting the patients to sleep. It's a misnomer, by the way. It's not CO2 narcosis. This should not be anything called CO2 narcosis. It served its purpose 40, 50 years ago. It's pH-dependent narcosis. So you are as sleepy with the same pH, whether it's metabolic or respiratory. If I give you somebody with 7.0 metabolic and 7.0 respiratory, they're both going to be as sleepy, right? So it's the pH that makes you sleepy, but somebody discovered it in COPD patients, so he called it CO2 narcosis, that's fine, right? But there is a lot of evidence for that. I see a lot of people, they tell me, well, I have a COPD patient and he came in with a PCO2 of 65, and so I hear the whole presentation and there's no pH mentioned. As if the PCO2, I don't care, PCO2 of 65 could be worse than PCO2 of 100. if the PCO2 is 100, is attached to the pH of 7.4. And PCO2 of 65 is attached to a pH of 7.2. You know what I mean? Like, it depends how acute it is, that's all. There's a lot of evidence. And anybody tells me that the PCO2 is what puts the people to sleep, I just end the conversation, because that is a low-level conversation. I'm not getting into it. It's ridiculous. I'm just going to give you that explanation and once and for all. I mean, patients who have 80, 7.39 and 80, they're awake. They're walking around in the community. They're doing intelligible jobs. You know, they're probably professors in college or whatever. Huh? With this, if PCO2 puts you to sleep, then there should be zombies in the street. All this, I can then know that this guy is COPD. Why? Because he looks sleepy and can't wake up. Come on, that's not the way it is. Also, when you have metabolic acidosis, and the patient is also sleepy because is very, very acidotic. What's the PCO2? PCO2 is very low. For metabolic acidosis, you've seen DKA patients or whatever, they breathe so fast they bring down the PCO2s like 10 or 19 or 15 or whatever. They should be more awake then, right? Because if PCO2 is the substance that makes you sleepy, you should be more awake. But it's not, it's the pH and the CSF, right? But I give them one thing. It is the acuteness of the problem that puts you to sleep. That's probably what made people confused. Until now, some people are confused about thinking that the PCO2 is what puts you to sleep. Why? Because the PCO2 crosses the blood-brain barrier much faster than bicarb. It crosses almost instantly. But bicarb takes about 4 hours. So if you are a COPD and walking around like this, you're not going to be sleepy. But if I give you 2 milligrams of dilaudid, your sleepiness, and you drop your pH to 7.2, let's say, you accumulate CO2 a little bit, and your pH goes down to 7.2, and this is the blood-brain barrier. It used to be 40 PCO2 7.4, and now you're 60 PCO2 7.2. What's going to happen is these two are going to equilibrate immediately. 60, this will be 7.2 immediately, and you'll be asleep. Right? Not from the dilaudid. I'm not talking about the dilaudid, at least from the pH. Right? If I close your airway and you just, raise your PCO2 or something, right? You're gonna get sleep. But metabolic acidosis takes time. So for example, if I have 7.4, 40, bicarb of 24. Now we have lactic acidosis, the bicarb goes down to 12. This is still 40, for example. And this is 7.2, let's say. This doesn't equilibrate. It takes 4 hours to equilibrate. So if you have that lactic acidosis patient that's running at this pH, right, he's not going to be sleepy right now, but down the line he's going to be as sleepy as the other one because it's already equilibrated. Right? So that's the difference. But we came to here just so we can talk about the compensation and the partial compensation. I'll give you a table that, going back, just to remind you, we're here. We're acute and chronic, compensated, partially compensated. That's the fourth step. There's a table here that I have never, ever used in my clinical life. And I promise you I'm not going to put a lot of junk in your brain, but this one is very easy to remember. And it might come in a test. So I'm just going to put it out there. It's not going to occupy a lot of gigabytes. It's going to be very, very simple. This is a change of the PCO2. So we're talking about respiratory use. This table is trying to find what is the metabolic disorder, metabolic compensation expected for different respiratory disorders. So for a change of PCO2 of 10, what is the expected change of bicarb? In the four disorders that we know, acute respiratory acidosis, acute respiratory alkalosis, chronic respiratory acidosis, and chronic respiratory alkalosis. That's the 4 respiratory disorders. There's no other respiratory disorder, right? The change expected from bicarb is 1, 2, 3, 4. So it's easy to remember. Respiratory acidosis, respiratory alkalosis, acidosis, alkalosis. Right? So obviously you can tell that chronic disorders have more time to change, and chronic respiratory alkalosis, very easy, relatively easier to compensate for because of the it's easier. The kidney will lose a little bit of bicarb, and that's it. You know, so that's your that table. I never used it because I really, literally, why do we need this? I mean, what if I do it and people get wrapped around it? What if, this is related to Winter's formula, but why do I do this? And if I find that the kidney did not make the change that it was supposed to do, what am I gonna do? Like slap the kidney on its pelvis? Bad kidney. You can't do that. Right? You just give bicarb and that's it. It was supposed to get changed by 4, it didn't. What am I supposed to do? Just give anything else. It doesn't matter. The pH is what matters, not the change in bicarb. All right, one more thing about this number 4 here. So let's say, just to highlight the importance of knowing that respiratory compensation for metabolic disorder happen immediately and metabolic compensation for respiratory disorder takes time. So let's say we have somebody who we diuresed, for example. He has contraction alkalosis, so 75 to 55, right? PCO2. Notice I don't give you bicarb because he can do everything without the bicarb. 7.52 and 55. So if you diagnose this is alkalosis. They're both going in the same direction, so it's metabolic alkalosis. So we're not going to do step number 3, we're going to jump to step number 4, and we're going to see is it compensated or partially compensated?
Sure.
Partial, right? Because it was a metabolic alkalosis. The body starts to accumulate CO2 to compensate, bring down the pH to what it's supposed to be, but it's not. But it couldn't do it fully. So let me ask you this. What would be the PCO2 to have full compensation? So it should be, do the calculation. 7.52, you want to make it 7.4, right? So that's like 0.12. So that's 0.08 plus 0.04. So it's about 15. So if I raise this, if the body managed to raise this by 15, reach to 70 PCO2, this pH will be normal, and that will be a full compensation for metabolic alkalosis. But the body didn't do it. So this is the 2 scenarios. Same pH, but 2 scenarios. The patient is breathing at respiratory rate of 6. The patient is breathing at respiratory rate of 20. What's your diagnosis here? So acute metabolic alkalosis, partially compensated by respiratory acidosis. Anything else you want to say here? In addition to all of this? So let's think about it. The patient is trying to accumulate CO2, so he dropped down his respiratory rate to 6, right? And don't believe anybody, especially if he's wearing a bow tie, that tells you that you can stop breathing completely for alkalosis. Nobody stops breathing completely. There's obligatory breathing. We'll come from here and say, breathe. You can't just stop breathing and kill yourself because you're alkalotic. Nobody does that. So there is obligatory some breathing, so like respiratory rate of 4, respiratory rate of 6, whatever, something like that. Right? So respiratory rate of 6, he did what he can. He dropped his respiratory rate to 6, but his lungs are so healthy that even with respiratory rate of 6, he could only accumulate from 40 to 55 PCO2. So that's the maximum compensation. This is a pure acute metabolic alkalosis, partially compensated by respiratory acidosis. But how about this one here? What is this patient doing? This guy's an idiot. Why is he breathing at 20? He's not supposed to, right? You're supposed to accumulate CO2. Why you're breathing fast? You're not supposed to breathe fast, right? So this one is acute metabolic alkalosis, partially compensated by acute respiratory acidosis, right? But in addition, there is relative acute respiratory alkalosis. Why? Because he was supposed to be 70, but he wasn't 70. He breathed himself down to 55 because he's breathing fast. So there is a third disorder here. that is actually has none unrelated to the metabolic alkalosis, and he is breathing fast for some reason that we don't know, right? That we have to like find, right? So we'll go through the list that maybe he's anxious. Which one of these two situations are more common in the ICU? This one. Most of them are here, not here. Because what? They're anxious, they're in pain, they're intubated, they're hepatic encephalopathy, they're anything that will make them breathe fast. And somebody's gonna tell me, you are crazy. You're saying alkalosis, and this is, how is it respiratory alkalosis when your PCO2 is 55? That's acidosis. It's a relative alkalosis. It's supposed to be 70, but now it's 55. So that's what we're talking about. It's relative alkalosis. Right? So now, number 5. That's if it's metabolic acidosis. So only applies if you're in metabolic acidosis. We're gonna divide you into anion gap metabolic acidosis or non-anion gap metabolic acidosis. And that's it, very simple. But in the ICU, you can't determine the gap without looking at the albumin, because people have low albumin and stuff like that. It's a little bit different than the ER when somebody comes with DKA, but in general, that's the right way of doing it. So the albumin affects your, it's a negative ion, so it affects your anion gap, and anion gap is basically the gap between the positive ions that we measure minus the negative ions that we measure. There's some ions that we're not charged, we're neutral. So there's some ions that we don't know, negative, that are flowing around in the blood, like lactate and phosphate and sulfate and all of these things, and we don't count them, and that's why we call them the anion gap. We know its number, so if this gap rises, then we know there's more of those negative ions. We have to look for the source. So that's the whole thing about the anion gap. Some acidosis, metabolic acidosis, are happen by accumulation of a new acid, so you have a lot of those gap, things flowing around in the blood, and some metabolic acidosis happen by just losing the bicarb, so that there's no accumulation of anything, it's just you're losing bicarb. So anyway, the way to do it, there's a formula in the book. We're not going to remember the formula. We're going to try to simplify it, but it's exactly the same number. I didn't change anything. You unravel it. So instead of remembering a formula, you remember one number, and the number is 2.5. Can you remember 2.5? You multiply the albumin times 2.5. That will give you the expected gap for this patient, right? The expected gap. So it's not everybody has to have a gap of 12 to 14. No, move away from that way of thinking. Just albumin times 2.5, that'll give you the expected gap for you. So if your albumin is 2, your expected gap is 5. And if you have a gap of 8, that's a 9 gap metabolic acidosis. If you decide to do it with the formula and stabilize the expected gap at 12 and change the measured gap based on the albumin, you're going to go through the formula, the brackets and all of these things, and then come up at the end with the same result, right? But easy to remember it this way, right? Next is if it's anion gap metabolic acidosis, and only if it's that. I see people do it for alkalosis, there's no need to. Pure or mixed. And that's where we do the delta. That's the last step, right? So let's talk about that. So basically, we have a patient with this 7.22 PCO2 of 30, bicarb of.
Oh, good! I learned something.
we have to turn this up. Turn it up, Professor.
Oh, what is it? Oh.
We're recording. That's fine. That's fine.